And good afternoon. I'm Dr. Discogenic, CEO and founder of Duke Spine Institute. You're watching Live Spine Surgery. We're broadcasting from our center here in Melbourne, Florida. Our patient travels here from Minnesota, 10 years of back pain. He's had even a fusion done on his spine, thoracic, in 2022, which did not work. He's had some complications from his fusion, but he didn't want to take any more chances. He went to the Mayo before he came to Duke Spine for proper care. You can see on his x-ray, there's a generator there, right? Jordan's going to show you that, Henry. You see that?
Yes, we do.
I believe that's a generator for a stimulator, right? All right. Now, this patient has back pain coming from 2 discs, 3 facets, an SI joint, and a piriformis muscle that's torn in his buttock. We're going to fix all those things. So he has 1, 2, 3, 4, 5, 6, 7 items causing his back pain. 7. We're going to start with the 2 discs, the L4-5, the L5-S1. He has a tear in the disc and he has discogenic back pain. We call that discogenic. Disc for where it comes from, genesis for creation. So the disc is creating the pain. He also has facetogenic pain, sacroiliacogenic pain, and piriformogenic pain. All right, let's get started. Shot. So we want to head down to L5-S1 first. Some num-num. Any questions, feel free to ask. The patient is sedated. He has no tube down his throat. He's just getting sleepy medicine in his vein. We call that sedation, twilight sedation. That's how we do the surgeries on the lower back. By the way, the first patient we did, the one you watched earlier today, doing fantastic. He is heading home as we speak. Shot. All right. You can see the needle is headed right towards L5-S1. Shot. Okay. Let's try a little something else here. Shot. Now, this patient here has a very high iliac crest. Shot. Why is that important? Because it makes it more challenging to get down to 5-1. All right, Jordan, I think we're off on 5-1 by quite a bit. Shot. You see we're off on WAG. You see the double pedicles? That's so much better. He must have moved, so that's really much better. Thank you. No, he's not moving now. So check out how high this iliac crest is. It's unbelievable. My disc is here. My entry point is way up here. I'm having to aim down. Hey, Pete. This is a very challenging case because he has a high iliac crest. Any questions, feel free to ask us. Thank you, Jordan. We'll do our best to answer for you. We're going to try to fix 2 painful discs in his back from 1 incision. Okay? All right.
At this moment, no current
Shot.
questions.
Why don't you show the audience the 30 different causes, Shot, of back pain?
Of course.
I'm Dr. R. Discogenic with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. Welcome back. You can see 30 different causes of chronic back pain. The disc is the most common. 85% of people, their primary cause of back pain is a disc problem. 10% it is a facet problem. So together it's 95%. So if you take 95% of people with chronic back pain, we can either be disc or facet as the primary cause. In his case, it's disc. He has facets as well, secondary. That's why we have facetogenic pain. Facetogenic, genesis means to originate from, facet means the facet joints. He has damage to his facet joints, arthritic facet joints. He has damage to 2 discs. And it's inflammation in the disc and inflammation in the facets that's causing his pain. We're going to go in and clean out the source of the inflammation, get rid of the inflammation, get rid of the pain. Do we have any questions?
Yes, we have a question coming from LQ on Twitter asking.
Can you grab a chair for me? Go ahead.
Asking, would knee meniscus tears be treatable at your clinic? What knee issues can or can't be treated by your clinic?
That's a great question. So meniscus tears are typically treated with different treatments. One is meniscus repair, where you go in and try to repair the meniscus by sewing it back together. And that's not a very effective treatment. It typically will fall back apart. But what we treat is knee pain. So if you have pain in your knee joint, so arthritic pain, knee joint pain, loss of movement in your knee because it hurts to walk on it, hurts to move it, typically that's going to be meniscus or it's going to be arthritis of the joint. And that's what we can treat. We treat it with our Duke plasma rhizotomy. We go in and make 3 little cuts. We destroy the pain nerves to the joint so the joint doesn't hurt anymore. And you can walk normally, have normal range of motion that you would normally have with the knee that you have without limitation by pain. There are some causes of knee pain like patellar tendonitis that we don't treat. I mean, we can treat it. I'm sorry, we do an injection. That's the treatment, is injection, but it's not treated with the Duke plasma rhizotomy. Then you have other causes of knee pain that are outside the knee joint, like pes anseranus. Is that what it is? Pes anseranus? Yeah, pes anseranus, which is basically tendonitis of the quadriceps tendon and some of the other tendons around the knee. Yeah, Baker's cyst, which is a big synovial cyst in the back of the knee, pain and limitation of movement. We can pop the cyst or drain the cyst. Sometimes it'll come back. So I would say the majority of knee conditions we can treat here at Duke Spine, Duke Joint. We have Duke Joint Institute as well. We're going to be launching our new website soon for Duke Joint Institute this year, probably in the summer. So we're in the process of creating more animations to explain what it is we do to treat these conditions. And once those animations are done, we're going to incorporate them into the new website and launch the Duke Joint Institute website. But for right now, we're dealing mostly with spine issues, but we do treat hip, knee, and shoulder pain as well. That's arthritic pain. We treat other causes of shoulder and knee and hip pain that are not related to the joint arthritis, but are related to tendonitis or bursitis by doing injections. That Dr. Patel is the one who does that. Dr. Damola does it as well. So yes, we can treat probably about 90% of knee, hip, and shoulder problems that are degenerative in nature, not trauma, not fractures. We don't do any fractures. Eventually we will. If we hire an orthopedic surgeon that does fractures, we can start doing fractures. But as of today, we don't have that specialty here. We don't offer it. Good question. How are we doing, Dr. B? Good, good. I have a feeling you were a little heavy-handed with the anesthetic. Yeah. So our patient is sleeping comfortably, but I do want him awake. I want to ask him some questions. So we're trying to let the anesthetic wear off. He is an avid athlete, I can tell you that. I can't tell you too much about him, but he's from Minnesota. He's very athletic. His back pain has been really keeping him from being active. He's an older gentleman. He's, how old is he? Around 65? 72. I was going to say around 68. He's around 68, 70. I can't give you his exact age, but I don't want to give away his identity. But he's, let's just say, close to 70. Okay? Very, very active here because he knows about our treatments, how effective they are, and he wants to get fixed. So, in a moment, we're going to do a discogram. I just need him awake to help me with the final positioning of the L5-S1 needle. And then we can get going on the laser for the 2 discs, L4-5, L5-S1. Any questions?
Yes. This question is coming from Lanu on YouTube.
Hi, Lanu.
Asking, the treatment for arthritis is limited with no cure. What advice would you give to anyone that has arthritis?
Yeah, great question. So arthritis is basically we call it a degenerative condition involving a joint. And the type of joint that gets arthritis is a name called a diarthrodial joint. It's basically where 2 bones come together and they don't join, but they're near each other, and there's a space between them or a gap. It's covered by synovial membrane, which produces a liquid. The bone surfaces have cartilage, so they're lubricated and they're slippery, and they basically slide past each other without any problem. When we injure joints through football, basketball, soccer, whatever sport you play, gymnastics, or motorsports, or some type of an injury to a joint, whether it's a car accident, slip and fall, sports related, you basically tear the capsule of the joint, and that allows the liquid to leak out. A lot of times during trauma you can bang the bony surfaces and you have chips in the cartilage where the cartilage gets damaged. So over time, over years, that joint will start to undergo structural changes. You start to develop a collapse of the joint where the joint, instead of being nice and fat and full of liquid, it's like popped like a tire, kind of sagging, and pressure is not there. Its bones come closer together, they start to rub on each other, and you get especially weight-bearing joints where the bones will start compressing on each other because of the weight, like your knee, your hip, and they start rubbing on each other. You get bone spurs, you get sclerosis of the bone, which is a thickening of the cortical bone just under the joint surface. You get bone spurs, which I said are osteophytes. You get thickening of the ligaments, calcification of the ligament. But most importantly, what causes the pain is you get inflammatory tissue growing into that tear in the capsule, or in the case of the disc, into the wall of the disc or annulus. So you get annular inflammation or synovial inflammation, and that's what really hurts. So what can be done? Well, until now, like before joint replacement or fusion, we used to do medications, but medications never fix the problem. How much longer? So medications have side effects. Medications can be toxic, especially if taken for prolonged periods of time. That does damage to your organs, increases risk of complications like heart disease or stroke, heart attacks, like anti-inflammatories do. Long-term steroid use has all kinds of complications. So we learned through trial and error as doctors that treating arthritis with medication doesn't work, all right, and has lots of bad side effects. So then came joint fusion and joint replacement, surgical treatments for joints, meniscus repair, arthroscopic joint surgery, those types of treatments. Great, but they don't work very well, and over time the joint continues to degenerate, cause pain. So these treatments have problems, right? Especially joint replacement, very invasive, bloody, painful, long recovery, could be a year recovery or longer. Plus they get infected, they wear down, you get wear fragments and loosening. So there's lots of complications. So along came a procedure called a rhizotomy. That's where it's real simple. You basically kill the pain nerve to the painful joint, and the joint pain goes away. And you can still keep your joint, move it around, does everything you want it to do minus the pain. So you got your natural joint minus the pain with normal movement that you can have limited by the arthritis, of course. That's where we are today. That's the most state-of-the-art treatment. That's what I recommend for people with arthritic joints. Come to Duke Spine and get our Duke Plasma Rhizotomy. How we doing? Boy, you just snowed the guy. But
Open your eyes, my friend. Good. Can you open your eyes for me? We're going to ask you a question.
are you having any pain?
Are you having any pain right now in your back? Any pain in your back?
Are you having any pain?
Open your eyes for me. How you doing?
You having any pain? Needs a little stimulation. All right, but I need him.
Open your eyes again for me. Open your eyes. Good.
So this is the kind of blood loss we have with the surgery. You guys see that? It's almost nothing.
Any back pain?
Yes, we do.
Any pain anywhere? Shot? That's it? AP? All right, so I'm at 5-1. Is he having any pain in his leg?
Let me ask you a question. Do you have any pain in your leg, in your back, or in your leg?
Okay, look at that. Just stay there for a second. Jordan, show the audience. Yeah, you can go to Lotto. He has a bifid spine. You guys see that? Spina bifida. He has a failure of fusion at the L5, 2 lamina, no, up. You see the 2, yeah, there's one there and there's one there. They should be one. Show him the one above at L4. That's a fused spine. Embryologically, when he was in the uterus, his lamina never fused properly. So he has an anomaly of his spine at L5-S1, which is probably contributing to my difficulty getting to where we need to be. How's he doing?
Open your eyes. I'm going to ask you a few more questions. Can you open your eyes for me? Are you having any back pain right now?
Any back or leg?
Any back or leg pain? Are you having any back or leg pain?
Shot. All right. We got to work on making sure that patients are more awake. Where do you feel that?
You having any back pain at all?
Where do you feel that?
Where are you feeling that? My friend, can you open your eyes for me? Are you having any back pain or leg pain?
Sean? So he has a very high iliac crest and he has an abnormal L5-S1 segment because of what we've seen. And that's making it extremely difficult. Where do you have pain?
Where's your pain?
Sean?
Where's your pain located? Are you having back pain or leg pain?
We need your help, my friend.
Say, I couldn't hear you. Say it louder. Where's your pain? Back or leg?
Fuck. All right. Any questions from our audience?
Yes, we have a question coming from Pawn Lust on YouTube, asking, do you treat wrist issues at all? I have some wrist pain and I know what caused it, but the MRI says it's fine.
If your wrist pain is arthritis of the wrist, then yes, we can treat it with our plasma rhizotomy. If your wrist pain is like a tendonitis, or look, in summary, the answer is yes. We treat wrist pain as well, as long as it's not a wrist fracture. So you're welcome to come here. You're welcome to do an MRI review and have Dr. Patel evaluate your wrist to see if we can figure out what's causing the pain. And depending on what the cause is, we have a treatment for the wrist. But again, if it's fractured, no. If it's not a fracture, if it's arthritis or tendonitis, then yes, we can fix it. How reliable is he?
Good. We're going to ask you a question. Do you have any back pain or leg pain? Keep your eyes open. Any back pain or leg pain? Yes or no? You said no or yes?
Hey, Jordan, will you try rotating orbital a little bit? Shot.
Back pain or leg pain? Any back pain or leg pain? You say yes or no?
I think the other way. Shot. That's better. Right there.
How are you doing in there? You okay?
We need you awake. We need your help.
Can you open your eyes? Good. Open your eyes. You have any back pain or leg pain?
You having any pain?
What, I'm sorry, I couldn't hear you. What did you say? What did you say? Any back pain or leg pain? Can you speak up a little bit for me? Any back
Shot.
pain or leg pain?
Oh, Jordan, what do you think about that picture? I feel like we're off on orbit. I don't know if he's moving or if it's just not. He's still off on orbit. What do you think about that? Better?
Okay?
That looks pretty good.
We're going to ask you a question. Do you have any back pain? Yes or no?
Are you having any pain at all?
You just said no.
You having any pain?
Are you having any pain in your back? You just said no.
No, not just the back.
Are you having any back pain?
You having any pain at all? Hello? Hello, McFly. Shot. That's such a weird picture, huh? It's just not going. Shot. There's something. Just doesn't add up. You having any pain?
Are you having any pain right now? Any back pain?
Shot.
You just said no. Are you having any back pain? Yes or no?
Not back or leg.
Leg. Are you having any leg pain, sir?
Yes, no? Hello?
How are you doing, my friend?
Where does that hurt?
Where's it hurting you?
Where does that hurt? AP? Unfortunately, his anatomy is pushing me away from 5-1 disc to get in. I'm not able to get in. Yeah, I'm right outside. You see that? Because of that spina bifida. And his facet, his iliac crest, all of it together, combined. No, making him deeper is not going to help. Not at all. And he's not really being helpful right now to us. So, shot. Yeah. I think I'm just too lateral. Shot. I could try starting more lateral, aiming more medial, but I'm hitting his iliac crest here. That's the problem. Could try pulling him lateral. See, shot. Too high. Shot. Still too high. Hitting his iliac crest again, that's the problem. Shot. Alright. Is he awake? Shot.
Can you open your eyes for me? Hi. Can you open your eyes?
Shot. Yeah, too high.
Open your eyes for me.
How bad is that on a scale of 1 to 10?
Give us a number. 1 to 10. Give us a number. I couldn't hear it.
How high is that?
What number? What number did you say? You said it. What did you say?
I heard 9. Is that where you get your pain? Alright, so we had to abort L5-S1 DLDR due to anatomical constraint. Anatomical constraint. Alright. You can see there's a tear at 4-5, and he gave us a 9 out of 10. So 9 out of 10, L4-5, L5-S1 not tested, unable to access due to anatomical constraint. So unfortunately, he has an anomaly of the spine that prevents us from getting in to fix it. That said, he's got lots of other things for us to fix. Henry, why don't you show the audience how we fix painful discs?
Of course.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. You've seen our video on how we repair painful discs, which is what we're doing right now. It's called the Duke Laser Disc Repair. It's done arthroscopically with a camera and a laser. The laser fiber is 1 millimeter wide. The precision is 1/20th of a millimeter. Sorry. Yes, 1/20th of a millimeter. And we are inside the tear and herniation at L4-5. Now, we tried to get into 5-1. We tried a lot, but we were unable to get in because he has some unusual anatomy that prevents us from getting in. And it wasn't even a huge facet. He had really just the angle of 5-1 combined with the high iliac crest combined with the facet combined with the transverse process position combined with the spina bifida occulta. All those things added together. And by the way, when I get into 5-1, it's typically just by a margin of a millimeter. So when you lose that millimeter margin, then you're basically in trouble. You're not able to get in to the 5-1. 5-1 is the hardest disc to fix. There's no doubt about it. Any surgeon that does transforaminal surgery will tell you 5-1 is the hardest. As a matter of fact, many surgeons don't even try to do 5-1 transforaminal. They just remove bone, do a laminectomy or hemilaminectomy, take out part of the facet joint. Unfortunately, that destabilizes the spine and makes the spine weaker. Grab her. We didn't do that, obviously. I don't want to weaken people's spines. I want to strengthen their spines, if anything. Any questions?
Yes, we have a question coming from Laney on YouTube.
By the way, look at that right there. You see that pink stuff?
Yes, we do.
That is the inflammation that we were talking about in the video. You guys are seeing it. And remember how the laser cleans it out and gets rid of it? In the video, that's what we just did. That's where the pain comes from, that red stuff right there. We don't always see it on every surgery, but it's there. It's there in every case. Yes, Laney, I'll take your question.
Asking, when you remove the herniated disc material, how much can you remove before there's too little disc material left to cushion the vertebral?
That's a great question, Laney. We are not removing any disc material. We're removing a herniation. Remember, the herniation is not in the disc, it's outside the disc. It's in the wall of the disc and outside. So we're not taking any disc material out at all. Great question.
Next question coming from Lanu on YouTube. Asking, have you ever encountered a patient that has an allergy, and will this interfere the surgery?
Yes, all of our patients are checked for allergies before we do surgery. We ask them if they have a history of an allergy. Many of them have allergies, and what they're allergic to are typically medications. Some are allergic to latex, some are allergic to iodine. But in the end, we check every single patient for their allergies, and it has never kept us from doing the surgery. Because we're not really using anything. We do use iodine. We use betadine. That's what you see us inject at the end. That's a antibiotic to kill any kind of bacteria that might be there if we accidentally got bacteria in there. But aside from the iodine, there's really nothing we use that would cause an allergic reaction. We stopped using latex in our operating rooms about, 6 years ago, 7 years ago? So we don't have latex anymore. We're a latex-free facility. And any kind of drug allergies we know about ahead of time. And we don't have a problem with drug allergies. I mean, nobody's allergic to propofol, right? Berndes? You ever seen a patient? Huh? All right, so what do you do if they have an allergy to propofol sedation? So we use Versed, fentanyl, and ketamine.
But it's probably, I don't know, I'd probably say 1 out of 10,000 patients.
1 out of 10,000 patients has a propofol allergy.
We have another question
Sure.
coming from Teresa on Facebook saying, hello everyone, Dr. Duke, can L4 to L5 disc problem cause ED?
Can L4-5 disc problem cause erectile dysfunction?
Correct.
Yes and no. Typically no, but yes, it can for sure if it's pinched nerves or if it's so much pain. A lot of times erectile dysfunction is caused by the pain being so bad. I mean, if you're in a lot of pain, how do you get an erection, right? It hurts. Your back is hurting you. You don't want an erection. You're not going to do anything with it. You're in too much pain. So, yes, an L4-5 disc problem can cause erectile dysfunction if you're in pain. Or if you're treating your pain with pills, the pills can cause erectile dysfunction, pain meds. So, now, could just pinching of nerves with no pain at L4-5 cause erectile dysfunction? It's unlikely. Very, very, very unlikely. But it's not impossible. So, I would say an L4-5 disc problem can cause erectile dysfunction in several different ways. Whether it's pain, whether it's the treatment with medication, and the medication's causing it, or whether it's pinched nerves. I think those are 3 possibilities of erectile dysfunction. But there's far more common causes of erectile dysfunction than an L4-5 disc problem. I would talk to your primary care doctor and have them, run some tests. But I would say L4-5 disc problem is not a common cause of erectile dysfunction. I could be wrong in your case. The case you're talking about. It's certainly possible. But it wouldn't be my first choice as far as causation. All right, we're pretty much done here.
More sacral nerve injury or trauma to the sacral nerves?
I'm not really, to be honest, an erectile function expert. Erectile function dysfunction expert. So I don't know a lot about all the causes, but there are doctors that specialize in that, and that's what I would do. Talk to one of them. All right, we're done. We'll be back with our rhizotomy next, so if there's any other questions, I'll take them now. Otherwise, we're going to wrap this up and come back with the rhizotomy.
Yes, coming from Lanu once more on YouTube, asking, You have done so many surgeries. Have you ever had a dream about surgery while sleeping?
Oh, no, I never dream about surgery. Probably because I have done so many, I guess, but never dream about surgery. I have other weird dreams, like most people, but never about operating.
And then lastly, coming from Rusty on Facebook, asking, can L5 to S1 facet joint cause a burning feeling in the lower back and hips?
Yes, it can. But if you want to know what's causing your symptoms, get your free MRI review with me. All right, thanks everybody for joining us. We'll be back for a facet treatment next.